So, respiratory emergencies. So, before we get into this, what are some common respiratory emergencies that you think you're going to encounter?
COPD,
Okay. COPD, asthma.
respiratory.
Yeah, so there's obviously a respiratory component to CPR because they're in cardiopulmonary arrest, right? What about in kids? It's super rare. It's one that we talk about, like it's one that gets talked about a lot because it's one that you need to recognize, but it is not something that you're going to see all that often. Croup is super common. Like guaranteed, probably everybody in the class will have a couple of those this year if you haven't already. Just now kind of getting time for that. RSV, some stuff like that. So several different viral type respiratory infectious disease processes that you're going to come in contact with. Yeah, the pneumonia. What about CHF? So CHF is caused from a failure of what body system? So it's a cause from a failure of the cardiovascular system. However, where do we see that? What system does that have a significant impact on? Yeah. So you're going to see a pretty significant amount of respiratory issues related to CHF, even though the way that disease process is truly defined, it falls in cardiac emergencies because it is because of a failure of the cardiovascular system, but it does cause significant respiratory issues as well, typically.
When she would move, one side would be absent. Sounds you couldn't.
Ugh, it's rough. Did you listen to the breath sounds?
I did because my medic was panicking.
What'd you hear?
What did I hear?
Yeah.
Just a whole bunch of junk. Just bronchi. But when we would move her, when I would sat her up, it would become absent on her left side. And then I didn't try, but tried putting her on a CPAP and she rejected it right away. So I put her back on a non-rebreather at 15 liters. She was a hoarder, so it took us like 35 minutes to get her out of the house.
Of course. Wouldn't.
It always starts out with right-sided heart failure, right? And then it progresses to left side, and that's when you have fluid in the lungs. No.
Left side first, I guess.
Yeah. So we'll cover this when we get to cardiology, but I'll tell you this quick little thing that it's pretty easy to remember once you hear it. What is the most common cause of left-sided heart failure? No. Myocardial infarction. So MIs, most common cause of left-sided heart failure. What's the most common cause of right-sided heart failure? Left-sided heart failure. Yeah. Right. So when the left side has trouble pumping the blood out to the body, where does that blood then back up into? The lungs. And that's where you get your pulmonary edema and all that kind of stuff. And then that will cause right-sided heart failure because then it's having to pump against all of that excess pressure in the lungs. So you typically don't see right-sided heart failure isolated by itself. You can see left-sided heart failure isolated by itself. That's not uncommon to see. But typically, if you have a right-sided heart failure, you're also going to have left-sided left side heart failure because they probably had the left side failure first. Right. So we get into chapter 17, respiratory emergencies. Right. So respiratory disease are a common condition that you're going to be dispatched to. what percentage of your calls are dispatched as some sort of respiratory component? A decent amount. I was going to say off the hip, probably half-ish, give or take, are some sort of respiratory component. Generally, it's pretty vague. Generally, it's just something like shortness of breath, right? What's my list of potential diagnoses for someone with shortness of breath? Well, it's about 74 pages long, right? So epidemiology, that's a big word. Anybody know what epidemiology means?
It's the study of
Where'd you get that from?
ology.
I like it.
Epidemia, I feel like, for some reason I think epidermis, but I know it ain't that.
No. So epidemiology is the study of the spread of diseases. Think epidemic. Yep. So epidemiology is the study of the spread of diseases. So epidemiology is very interesting. Anybody in here ever taken a statistics class for anything? So if you've taken statistics, epidemiology is all of that god-awful statistics word problem stuff put into healthcare, where us people who are sitting in this building right now find it actually to be pretty interesting. I actually got to take a class in my bachelor's degree on epidemiology, and it was very interesting. You had to learn how to do a bunch of different calculations and things like that. Have you ever read like a medical research paper? So the numbers that you get in there, like your confidence intervals and stuff like that, so those are all statistics calculations. Another thing that you see commonly in academic medical research papers is something called like a number needed to treat, things like that. So looking at that from the epidemiology side, that is the number of people that we need to give this treatment to before we have at least one of those people that have a positive outcome because of the treatment. So basically, the lower the number needed to treat, the better the treatment is in most situations. So some numbers: asthma and COPD, pretty common cause of death and disability. Right? There's about 16 million Americans with COPD and about 25 million with asthma. Okay. Now, depending on what textbook you reference, you may see that combined as 41 million people with COPD, because technically asthma is a chronic obstructive respiratory disease. Okay. So you may see asthma classified as a subtype of COPD. Asthma has its own subset of symptoms, but it all fits within the broad umbrella of what COPD requires for a diagnosis. That's just in general. Those.
I know the textbook was saying that asthma is not chronic until it reaches adult.
They will not diagnose you with chronic asthma until a certain age. And I don't remember exactly what that age is.
They were saying asthma in children is from not intrinsic, but the other one.
Extrinsic? Yeah. Typically, yes. So it's typically from environmental factors, not from an actual problem with the respiratory system in the body. So it's typically you get swelling of the bronchioles and things like that related to some sort of environmental factor like an allergen, seasonal allergies, hay fever, things like that. You'll see asthma-like symptoms. They fit all of the things to check the box to be asthma, but they won't diagnose you with chronic asthma until you're an adult. Correct. Yeah. Pneumonia, one of the most common causes of fatal illness in developing countries. Okay. So Pneumonia. Where does pneumonia come from? Okay. And isn't it, where does that infection start when we're classifying pneumonia? So we know that it is in the respiratory system. What piece of the respiratory system does that infection? Yeah. So it's in the actual lung tissue itself. So an infection in the lung. So more commonly it is on one side. More severe cases you will see it spread to both sides. Typically doesn't start on both sides. It typically will start on one side or the other. Any guesses on which side is the most common? Why would that be? That is correct.
I think I remember reading about that.
So it is most common to see, or it's more common to see it on the right, as if we think about the way that the trachea branches, which one has a more direct path to the lung itself? The right. So if it is a more direct path, that means that it is easier for infectious materials to get into the right lung. So that is why you would see it more commonly in the right versus the left. Right? And then we can also have respiratory disease processes or respiratory illnesses that are genetic in nature or caused by some sort of external factor. All right. So what could be an external factor that could cause a respiratory disease process? Yeah, mold. Any kind of allergen, really. And then you've got all your infectious materials. All of those are all external, until you bring them into your body. So viruses, viral particles, other bacterial particles, fungal particles. You can have several different types of pneumonia. You can have bacterial pneumonia. You can have like a viral type pneumonia. You can have fungal pneumonia. That's super nasty. That's not common here. It is common in other places, but not here because we have mostly clean places to live in the U.S. We're not living outside where we're exposed to, all kinds of different fungal spores and things like that. We don't, even though contrary to what it has been like the last couple of days, we don't live in a rainforest. So several different things. We'll get into some anatomy and physiology review. So primary structures of the respiratory system. So we talked about the airway stuff before. So we talked about the upper airway, which was the oropharynx, the nasopharynx, the laryngopharynx, the larynx. Then you have the trachea, the vocal cords, the epiglottis, all of those structures in that upper airway. And what was the structure that was the dividing element between the upper airway and the lower airway? The glottic opening, right? So today we're going to focus on things that affect everything below the glottic opening. So really everything that is above the glottic opening is an airway issue because it's blocking the passage of air getting into the respiratory system. And then we have everything below the vocal cords, which is anything affecting the tissues below the glottic opening is directly affecting the actual function of the respiratory system, not just the flow of air into and out of the respiratory system. So on the left here, we have a picture that represents what your Your right and left mainstem bronchus would enter the lung, and it would enter the lung here in this representation, and then it would go down, and here where you see these main branches, those would be bronchioles. And then we get all the way out to here. All of these little branches are still bronchioles, okay? And then at the end of those bronchioles, they terminate in the alveoli, right? So we have the tracheobronchial tree, or the tracheobronchial tree. The trachea, what purpose does the trachea serve? So it's a passageway for air to get into the lungs, right? It goes from the larynx, which we've already learned, and it extends down to the mainstem bronchi. That is typically about 4 to 5 inches from the larynx to the carina, where the bronchi, or where the right and left mainstem bronchi split off. We have the right mainstem bronchus. It is at a less acute angle. Most of your pictures like this don't do a good job of representing it, but up here you can see that the right kind of goes straight, just a gentle curve over to the right side, and then to the left it is a much more significant angle. All right. Again, those mainstem bronchi, they branch out into the lobes of the lung, and then they go into the tertiary, subsegmental bronchi, and then the bronchioles. Okay. And then we call all of the air that is in just the passageways, all of that space is referred to as dead space. Okay. So dead space is a term used to describe airway components where the volume of air in there is not participating in gas exchange. And this dead space is higher in patients that have some form of respiratory disease. So think about, we've got our larynx here, got our trachea here. So the little circles there represent your alveoli, and then all of your all the blue lines here are your tracheobronchial tree structures. Right? So pretty obvious to see that all of these little alveoli here are going to be filled with air as long as we're able to breathe an adequate volume in, right? So everything here is going to be air that participates in the respiratory process or the actual respiratory gas exchange reactions, things of that nature. Then all of this here all of this is air that does not participate in respiration, because where does respiration happen? In the alveoli, right? So all of this is dead space. So that is useless to our body, right? So we're not getting anything out of that. We're not putting waste into that. It's not doing anything for us. Obviously, we had to have it, because if all of that was empty, there wouldn't be any air in the alveoli, right? So basically, everything from the point where air enters the nose and the mouth until it gets into the alveoli is considered dead space. Right? So a significant volume of the air that we breathe in and out never leaves the dead space. Right? Now, there's a much higher concentration of the alveoli in a real lung compared to what I drew up here. You've got thousands of those little tiny alveoli inside each lobe of the lung. So your volume in the alveoli is still quite significant. However, there is still a good portion of the air that you breathe in that never participates in the gas exchange. Okay. In the bronchioles, so the bronchiole itself doesn't participate in gas exchange, but the bronchiole delivers the air from the trachea to the alveoli where that gas exchange happens. Okay. Now, remember we talked about inside the trachea we have cilia. Yes. And what's the purpose of those fibers that are moving? Yeah, so to catch foreign particles and to help carry up mucus and things like that out of the alveoli so that the alveoli can remain fully functional.
We have cilia in our digestive tract.
You do, yes. Mm-hmm.
That's where it aids in.
Yes. Yeah. So here it still aids in movement. In the digestive tract, it aids in movement through the digestive tract. The cilia in the respiratory system, it functions to move stuff out of the respiratory system. All right. So the bronchioles do not have any cilia. So if you get something, some sort of liquids or secretions or anything like that, past the point where your main stem bronchus divides into the bronchioles, that we do not have cilia to transport that back up out of the body. So at that point, the only thing that we have to eliminate that and get that mucus or those secretions or whatever those foreign particles may be is to cough. Yep. So the bronchioles do not have any protective mucus. Okay. So they don't have any kind of rigid structure to help protect them or anything like that. So the bronchioles are very delicate. So why would...
They bleed easily when you have a chronic cough or very
Correct, yes.
especially with like dry conditions.
Correct, yes. So that we have smooth muscle that surrounds the airway structures. What type of receptors does that smooth muscle respond most readily to? So that's the actual pieces in.
Was it the nicotine receptors?
So nicotinic is responsible for muscle movement. So we're talking about smooth muscle and the constriction or dilation of that smooth muscle. Do you remember what receptors function in the lungs? So we have so it's covered in smooth muscle, so that smooth muscle can expand or it can contract. Okay, so when it expands, I get so when it expands, I get dilation of the tracheobronchial tree. Okay. When it contracts, I get narrowing of the tracheobronchial tree. Okay. So now this get more air movement here, we get less air movement over here. Right. So is that pretty logical to follow there? If the pipes get smaller, we're moving less volume through them, right? So,
Like a bronchoscopy. Oh, okay. I was thinking way too deep.
So then if we antagonize those beta 2 receptors, we get dilation of the tracheobronchial tree. Bronchodilator. Yep. So bronchodilators are beta 2 agonists. Okay. And I put the wrong word up there. It's the wrong A word.
For some reason, I didn't realize your question was just surface level.
Yeah. So then if we So if those beta 2 receptors are antagonized, we get constriction. Okay. Now we don't give anything really that's going to cause a significant amount of constriction there. Most of all the drugs that we get are going to cause dilation, right? Now,
And that's why bronchodilators don't help with anything that's not constricting.
correct.
Yeah, that's why you wouldn't give it an FCHF patient.
You could give it to attempt to relax the smooth muscle to hopefully be able to, with positive pressure, move more air. So they are helpful in the fact that they will relax the smooth muscle, which will allow those structures to expand when we're giving positive pressure ventilation. They're not going to cause those structures to just magically get bigger. So magnesium is it is a smooth muscle relaxant.
So you could also use that.
Yes. Yes.
That's why mag sulfate, if it's unresponsive to
Yeah.
bronchodilators.
Yeah.
Mag sulfate's indicated.
Yeah. Now, it is not as fast acting as an inhaled bronchodilator, but it is much longer acting than an inhaled bronchodilator. So your rescue medication should always start with your inhaled bronchodilator because that's going to get you the most immediate effect.
Then consider your epi 1-to-1 IM. Then
I would, depending on the severity of the patient. If the patient's peri-arrest, then yes, I would go epi. If the patient is not in a peri-arrest situation, I would go ahead and give the mag.
that's what we
First.
We skipped the epi. And
Yeah.
He responded to that.
Yeah.
The Dex.
The only time I would give the epi first is if I believed it was related to an anaphylaxis problem. 2, if they were peri-arrest, I would go ahead and give the epi.
So I know hands heavy takes it out of it's out of order in the way you should do it because we're giving, and also it says methylprednisone in our hand heavy tree, but we all know we're supposed to give dexamethasone.
Yeah.
But-
It could be either or.
Yeah, but we just don't have methylprednisone.
Correct.
And then I know it's out of order because the dexamethasone is for a later reaction because the onset's 2 to 4 hours depending on what you read. No.
Nah, I mean, you're going to see effects in like 40 minutes or so.
Yeah, but the mag sulfate's going to be the more immediate. Then we can give the dex, right? Or is it?
So realistically, you're probably going to be giving all this stuff at kind of the same time.
Yeah, if you got a competent partner, like she was giving dex IM while I was.
A realistic flow is you're going to start your inhaled bronchodilator, right? And you're going to do that either with a traditional nebulizer or via CPAP, depending on the patient's necessity.
The best fucking thing we've gotten on our trucks now is the actual nebulizer mask
Mhm.
instead of the handheld.
You always had nebulizer masks.
Well, I guess maybe because now we're running all of these like
Yeah.
super respiratory calls. But
You've always had nebulizer masks.
I've
You just pull the bag off the non-rebreather and plug the nebulizer T piece into it.
Oh, that's what I'm saying. Now they're coming pre-connected
Yeah.
instead of me
Yeah.
grabbing off
Yeah.
and ripping
Having to make one, yeah.
Man.
I much prefer the mask over that because a lot of your patients are elderly and they don't have teeth, and it's very difficult for them to hold that. And I need to be doing other things versus holding it for them while they're trying to get it. Yeah.
And blood pressure's taking the right arm, trying to get out of the left, they're holding it.
Yeah.
So take your hat off, put your left hand here.
So our alveoli, again, we've covered the alveoli quite a bit. So the alveoli are surrounded in capillaries, and they are the component of the respiratory system that actively participates in gas exchange, right? So I'll do a quick little recap here. So a little drawing that I made up there, that is the larynx at the top, the trachea, the right and left main stem bronchi, the bronchioles, and then the circles at the end of the bronchioles represent the alveoli.
Which is what CPAP is meant to open up.
Correct.
To
Yeah.
the gas exchange.
So all of the air that you see filling the circles for the alveoli, that is air that participates in respiration. Okay, so gas exchange is happening in that volume of air. Everything else does not participate in respiration. It participates in ventilation, but not in respiration. No gas exchange happens anywhere where you see the red squiggles. So basically, all of that space that is not participating in gas exchange is called dead space. And your dead space is basically everything from the entrance to the nose and the mouth to the alveoli. So all of the volume of air between your mouth and nose and the actual alveoli is considered dead space ventilation because it doesn't do gas exchange. We still have to have that dead space ventilation because if all of those structures were empty, there would obviously be no air in the alveoli. So it is important, but it doesn't participate in gas exchange.
So like getting the breath knocked out of you, you lose
Yep.
that, but you still have the air
Yeah.
that's traveling.
Yep. Mediastinum, so that is the medical term that we use to refer to the space in the center of the chest, right? So easy way to remember that is the space directly posterior to the sternum. Right? So everything behind the sternum is in the mediastinum. Heart, large vessels, large conducting airways, and other organs. Okay? So heart sits mostly in the middle of the chest. You have your large vessels, so you have the aorta and superior and inferior vena cava passing through the mediastinum. Then we have our large conducting airways, so that would be the trachea and the right and left main stem bronchus pass through the mediastinum. And then other pieces of other organ systems, things like that. Other vessels, pieces of the nervous system, stuff like that. Pulmonary blood flow. So anybody have any question about how blood gets from the heart into the lungs? So what chamber of the heart pumps blood into the lungs? Okay. And when it comes back from the lungs, what chamber of the heart does it enter into? Okay. All right. So those pulmonary capillaries are very tiny. Right. So they're the little tiny capillaries that are surrounding the alveoli. They're super small. Couple of things to know here. There's something referred to as polycythemia. So what does poly mean?
It's a color. Polyuria, it's a lot.
A lot. Yeah. So polycythemia is excess of red blood cells. So overproduction of red blood cells. Okay. So those capillaries, red blood cells typically pass through capillaries in a single file manner. So if we have an excess of red blood cells, you can get a backup in the capillaries because they get stuck, like they get wedged together in the capillaries. All right. So if I have an occlusion of the capillary, does that alveoli get to participate in gas exchange now? No. Then we have cor pulmonale. All right. So cor pulmonale is a term used to describe right-sided heart failure from COPD. Okay. So it's not just right-sided heart failure, it's right-sided heart failure specifically from COPD. I'll give you a little example of how that works here real quick. So we've got our So we've got our basic heart here divided up into our chambers, right? So we've got right atrium, left atrium, right ventricle, left ventricle, right? Then we have from the right ventricle, we have our pulmonary arteries, right? And then our pulmonary arteries, they will go down, continuing to divide and get smaller, and we reach our alveoli. And then all around our alveoli, we have our capillaries. All right. So this would be in a normal lung here. Everything is open. Blood's able to flow through the capillaries. No big deal. Right? So what if we have COPD?
You're gonna have fluid or secretions filling that space.
All right, so this is our COPD, right? So could be swelling, fluid, secretions, etc., whatever. So what that does is that so all of those things increase the pressure that is required for adequate pulmonary circulation to happen, right? So when this happens here, then this that increases the workload of our right ventricle. Over time, causes failure of the right ventricle. Okay? So we get right-sided heart failure. Now, this whole process here So cor pulmonale refers to right-sided heart failure that is secondary to that increased workload over time on the right ventricle because of the COPD disease process, right? So other right-sided heart failure is caused by same kind of mechanism, but instead of the increase in pressure being caused by the chronic inflammation of COPD, it is caused by the backup of blood into the pulmonary capillaries because of a failure of the left ventricle, right? So you're So your traditional right-sided heart failure is from backup of that blood into the capillaries because of a failure of the left ventricle. Right. Perfusion. Any questions about perfusion? I think we've probably beat that horse enough, right? So, okay, was saying COPD there with the alveoli on the right. We got the inflammation, fluids, things like that. Any of those things that cause the chronic obstruction process to happen, that increases the pressure required to pump an adequate amount of blood through those pulmonary capillaries. By increasing the required pressure at the pulmonary capillaries, we increase the workload of the right ventricle. Over time, the right ventricle working at a higher than normal workload will then start to fail. Okay? So that whole process there is the cor pulmonale. So right ventricular failure because of COPD.
So it would be a bad day if we released, or if we lessen the preload of the heart. Like, would nitro be a worry for us in a COPD patient?
Could be.
Just something to watch for with blood pressure.
Yeah. But we wouldn't typically give nitro for COPD.
Right, but if they were, STEMI or something.
Right.
Okay, cool.
Could be something to watch out for.
Gotcha.
I wouldn't say that it precludes you from giving the nitro to that patient, but you should also be prepared to help the preload. How can we help the preload?
Fluid bolus and or pressors.
Yeah.
Now, are we allowed to do push dose press? I know nationally we are, but fuck it, no.
For medics?
Yes.
Yeah.
Oh, they can.
Mm-hmm. Yep. It's not listed specifically, like called out in the guidelines, because I don't want people to just use that. I want people to hang a vasopressor infusion.
Yeah, if you're doing more than one pressor or more than one push.
Yeah. So basically, if you're going to have to give one, you should give the one, and then immediately you should start mixing your vasopressor infusion. If you have to give a follow-up dose of the push dose epi, at that point you should connect your vasopressor infusion to the patient and start it. All right. Mechanisms of respiratory control. All right. So cardiovascular regulation. So how does cardiovascular regulation affect the respiratory control system? Well, what if our cardiovascular system is pumping blood way too slow or at way too low of a pressure?
Body's going to try to compensate other body systems.
Yeah. What about if it's pumping way too fast or at way too high a pressure? Our body can't compensate too much for that in the pulmonary system. So what you run into the danger of there is you run into danger of damaging those delicate capillaries around the alveoli. Somebody missed a typo. This says Heath failure. Should be heart failure. A heart failure is caused by changes in fluid balances, right-sided heart pumping pressure, and the left-sided heart pumping pressure. And that is basically what we summarize here with this picture. So you can have right-sided heart failure because of a problem with the tissues in the respiratory system, or you can have right-sided heart failure caused from a left-sided heart failure, which then causes blood to back up into the capillaries of the pulmonary system. And then that would lead to blood backing up into the right ventricle and then the right atrium, then out into the systemic circulation, and those are where we see the edema and things like that. Okay. Muscular control. What type of pressure system is our normal breathing controlled?
Or negative.
Yeah. All right. So, anybody have any trouble understanding how that negative pressure system works. We talked about that quite a bit and how the diaphragm causes that negative pressure to happen. So basically our thoracic cavity is sealed to the external environment under normal conditions. So when our diaphragm flattens, what happens to the pressure inside the thoracic cavity? So the size of the thoracic cavity does what?
Decreases. Remember, it flattens, pushes down. Oh, in the thoracic cavity.
Yeah.
Increases.
Yeah, so the size of the thoracic cavity increases, which does what to the pressure?
Decreases.
So it causes the pressure to drop, which then causes what to happen? Air gets sucked in from the external environment into the lungs. That's a normal respiratory process. That's the normal negative pressure system, right? And then when our diaphragm relaxes, what happens to the size of the thoracic cavity? It decreases. So when that size decreases, what happens to the pressure? Pressure increases. So then what happens to air? Goes out into the external environment. Right. What about if we have a traumatic opening?
Oh, you can lose air, or it can be filling the space with blood.
Yeah.
Pressure on the systems.
Yep. So here what you see happening is we have a hole in the thoracic cavity, from some sort of penetrating trauma. So what happens now when my diaphragm flattens here, what happens to the space inside the thoracic cavity? Still gets bigger, right? But now instead of just causing air to be sucked in through the mouth and the nose, I also get air that's sucked in through this hole right here.
Which can't be used because it's not in the respiratory system.
It's not in the respiratory system, right? So it fills the space in the thoracic cavity. The problem with these is these are typically not nice, pretty, clean, completely open holes. If this was a perfectly open hole, this would not be a problem because air would go freely in and out of the hole. But what happens is air gets sucked into the hole and then there's not enough pressure to push it out. So with every breath, more air gets trapped in the thoracic cavity. Same thing happens if we have a hole in the lung. Okay? So if we have a hole in the lung itself, there's air that gets sucked out of the lung into the thoracic cavity. It doesn't get pushed back through that hole into the lung. It stays trapped in the thoracic cavity. Right? So ultimately, both of them will end up in the same situation where you have all of this white space here is meant to represent air that is trapped in the thoracic cavity. Right?
And then that's when, if the air is stuck in the thoracic cavity from the lung, that's whenever you would look at needle decompression.
Well, it doesn't matter if it's from the lung or from a hole in the chest.
You'd still needle decompress that.
Yep.
So I was thinking like second chest wound would be the three-way valve to not allow air in but allow air out.
The problem is most of the time that will, depending on the size of the opening, a lot of the times the problem is the air can't get out through that opening because it's jagged and you've got tissues that are overlapping. There's enough negative pressure to suck air in. There's not enough positive pressure to push it back out of that same opening.
So then it would be
So
to seal the hole and needle decompress.
my personal way that I look at it is if I need to control the air movement into and out of the chest in a manner that is not the nose or the mouth, I want it to go through a hole I made, whether that be with a needle or a scalpel, either or. Okay. Renal status. So again, what are the two main buffer systems in the body?
Bicarbonate buffer system.
And where does that one come from?
The
What organ?
I want to say kidney.
Yep. And what's the other buffer system?
Adrenal.
So it's called the carbonic acid buffer system, but it is from the respiratory system. Okay. So it's altering the level of CO2 in the body through the respiratory system. So if we have a problem with the renal buffer system, because that is the one that's more long acting, right? So the renal buffer system, if we have a problem there, then what does that mean about the buffer system from the respiratory component? Well, if we have a failure on that bicarbonate buffer system, what is the only other buffer system that we have? The carbonic acid buffer system. So what does that mean about the workload on my respiratory system? It's going to increase. Can I do that for a while? I absolutely can. But it will fail eventually if we do not fix the underlying problem. Sometimes the body can fix that underlying problem on its own. Sometimes it cannot.
Then older populations or people who are already at risk is going to have less of a time frame.
Yep, correct. Yep. Old people, young people, pregnant people. You will learn that those are your at-risk populations for everything. Old people, very young people, pregnant females, and people with any chronic disease process. Notice I said chronic disease process, because chronic disease processes permanently alter the function of other organ systems. All right. Hypoventilation. Anybody have any questions about hypoventilation?
Hypoventilation causes you to have high pH or high CO, low pH. So,
CO or C. There you go. All right.
so it'd be the respiratory system would be alkalotic because it's retaining the CO2, but that would make the pH be acidotic.
We ain't got that far yet.
Okay.
You can have either of those in isolation, or you can have something called mixed, which is both. We will get to that. We're not there yet. So you're on the right track, but that's not a definitive yes-no answer.
Okay.
Okay. So typically, keep in mind, we are only talking about the respiratory system in isolation here in this example. In hypoventilation, it causes CO2 buildup in the blood, which does what to the pH of the blood?
It lowers it.
Lowers it, which makes us more
Acidotic.
acidic. Yep. Causes of hypoventilation. Atelectasis. Anybody heard that word before?
Is that muscle?
Mm-mm.
It's like a your lung.
So atelectasis is collapse of the alveoli. Right. Pneumonia, pulmonary edema, asthma, COPD. So with asthma and COPD, why do we have hypoventilation?
Because it's constriction or a space.
Constriction, inflammation, it decreases the volume that we have inside the respiratory system. So that decreases the amount of gas that I can have participating in respiration. Makes sense on that one. With the pneumonia and the pulmonary edema, that is directly affects gas exchange by altering the permeability of the membranes. And it alters the permeability of the membranes by filling the alveoli with secretions or causing swelling of the alveoli, the alveolar tissue. When that tissue swells, makes it harder for things to pass through it. Right. So the thinner the membrane, the easier it is for stuff to pass through. If it's swollen and thicker, that means it's going to be more difficult for things to pass through it. All right. Problems that impair the mechanical piece of breathing. Flail chest. Anybody know what the definition of flail chest is? Yeah. So there is a technical definition for it, and the technical definition is 2 or more ribs broken in 2 or more places.
Oh, so they can't be consecutive for the definition of flow.
Stand by.
My wife says snowing at the house.
Where do you live?
On top of, the patient fellows. Done that. Watch it out of the yard. I don't know about that.
So I'm not gonna put it. Correct.
Getting home.
Yeah.
All right. So these little guys right here will be our ribs. All right. Now, if I have a fracture here, and a fracture here, and a fracture there, what do I call that? Flail chest, by its definition. No. How many ribs are broken?
3.
How many is broken in at least 2 places? 1. Now, if I were to have a fracture like that, then this whole area right here would be called a flail segment. Right? And with the flail segment, a lot of times you'll get something called paradoxical movement. And what that means is whenever I breathe in, what happens to my rib cage?
Push out.
It expands, right? So that little segment right here in the middle wouldn't expand with it. It would kind of sink in. And then whenever I breathe out, what happens to the size of my rib cage?
Lowers.
Decreases, right? Well, this little segment right here a lot of times will actually go the opposite way, and it will kind of stick out at that point. So we call that paradoxical movement. All right, diaphragmatic rupture. Well, if we break the diaphragm, that's a problem, right? It's pretty obvious. Severe retractions. Where do we see retractions?
Be in your belly, right?
That's accessory muscles. Where do we see retractions? You can't see the diaphragm. Intercostal muscles. So you'll see it as like a sinking in, like you'll see the sinking in of the muscles between the ribs, especially in kids and especially in people that do not have a lot of fatty tissue, like tall, skinny people or old people that do not have a lot of adipose tissue. Yep. Like all of those people, like malnourished people, alcoholics, things like that, a lot of times you will be able to see them really well in all of those populations. And anybody who has a decent amount of musculature or adipose tissue, they're going to be very difficult to see. And if we've got air or blood that fills the abdomen, why could that be a problem with respiration? Yeah. Abdominal or chest binding. So what if I put something around your chest that limited its ability to expand? Would that affect my ventilation? Yep. Or if I do the same thing to the abdomen, while we don't consciously think about it, you do use abdominal muscles in your normal breathing process. So if we constrict that significantly, that can affect our ability to adequately breathe. Because if we constrict the abdomen, what does it do to those abdominal organs? They're kind of squishy and freely movable, right? So that means they kind of squish out of the way, which then causes them to take up space by pushing the diaphragm up into the thoracic cavity more, which lowers our ventilation volume, right? And then obesity, the obesity hypoventilation syndrome, that means that they don't have enough musculature to physically expand the chest to get an adequate movement of air volume with each breath. Oh, the Pickwickian. Yeah. I was trying to decipher what the technical term was, but yes. Yeah, I've always heard it called, let me see the word again. I've always heard it referred to as Pickwickian. So, again, hypoventilation, this can come from problems with the nervous system control of the respiratory system. So that one's pretty obvious. If I break the controller module to the respiratory system, it doesn't work right. Everybody agree with that? So head trauma, spinal cord injuries, Guillain-Barré syndrome. Everybody know what that one is?
I know it's paralysis that starts in the lower extremities and works its way up.
Yep. And then we have amyotrophic lateral sclerosis or Lou Gehrig's disease, which is a neuromuscular disease, which will ultimately cause your diaphragm to stop being controlled by your nervous system. And then botulism. Mm-hmm. So, did you know that we have people that go out and pay hundreds of dollars to get botulism injected into their bodies? Yep. Where's the other place that you'll see botulism? Those are silicone or saline. Where would it come from in the Waffle House? That's a good potential option there. So, canned food. You ever heard that if you have a can that is swollen that you should not eat it? So what happens there is the reason that it swells is because of a buildup of gases inside the can, and that gas is usually building up because of the presence of botulinum, which is converting whatever's in the can into a gaseous material when it digests it. And then other things that just reduce your respiratory drive, opioid overdoses, intoxications, head injuries, asphyxia, things like that. Then we go to hyperventilation. That's the exact opposite of everything we just talked about, right? So instead of acidosis, what does hyperventilation cause? Alkalosis, yep. So some treatments for hyperventilation. So sedation, that would be a very extreme measure. Like, we would not typically want to sedate somebody who's hyperventilating. Why might that be a dangerous thing to do? They could be hyperventilating because their body says we need to, right? The best thing that we can do for most cases of hyperventilation is just psychological support. All right, so we'll get started back with patient assessment. What are some things that we think might be important for patient assessment dealing with respiratory emergencies. Okay. Okay.
And medical history.
Okay.
Any allergies they have, rule out like Atrovent, current medications they're taking.
So we need to do a thorough assessment, right? So thorough being a key word there. There's a lot of these respiratory illnesses or emergencies that
It's reading my card.
that's cool.
You can use it to check out. It's fascinating.
But I mean, a good portion of these respiratory emergencies could pose a significant risk to life. Right? Something about getting air into and out of the body is pretty important, right? Don't get sucked into just because their breath sound okay doesn't mean that they don't have a significant respiratory emergency. So, scene size up. So what's a couple things we're going to always do with scene size up, no matter what kind of patient it is? So scene safety. What else? Yeah, so BSI, scene safety. Now, what are some scene safety considerations that apply to someone specifically with a respiratory complaint that you want to be mindful of?
Like where they work, their conditions, factory workers, mill workers.
Yeah,
people
could
are
be.
exposed to like pathogens constantly.
Yeah. Gases, things like that. Diminished oxygen concentrations. Yeah. Carbon monoxide, other irritant gases, things like that. And then highly contagious respiratory illnesses. Right. So what can these respiratory diseases impair? Well, ventilation, which is what?
The actual act of breathing in and breathing
The movement of air, right? Diffusion. Where does diffusion happen in this whole respiratory system process? We're talking about the respiratory system in particular. Where does diffusion happen? Yep. Gas movement across the membrane in the alveoli is by diffusion. Perfusion. What does that mean?
in the blood.
Yeah, so getting the oxygen to the target tissue, the oxygen and nutrients to the target tissue. Or it could be a combination of all three of those things. All right. Now, we get into some more respiratory specific things. So if you have someone who has rapid onset dyspnea, what's dyspnea?
Difficulty breathing.
Yeah, difficulty breathing, or they're probably going to tell you shortness of breath. Is probably how the patient's most commonly going to describe that. Okay. So some of the things that should be red flags if someone has shortness of breath that started 10 minutes ago. Acute bronchospasm. Now, it doesn't say what caused the bronchospasm, so that could be anaphylaxis type reaction, anything that can cause bronchospasm, right? Anaphylaxis listed itself there. Pulmonary embolism. What is a pulmonary embolism? Well, first of all, what's an embolism?
Air where it's supposed to be.
Doesn't have to be air.
Something.
Something that blocks flow of vessels or blocks the blood flow in the vessel. In this case, it would most likely be a clot. It could be a foreign body, but we'll say almost always it's going to be a clot. Yes. Pulmonary embolism, that typically happens when you get a clot that is small enough that it passes through your systemic circulation without any issue. But when it gets into the pulmonary circulation, that is a much smaller vessel. So it gets lodged there. And then when it gets lodged, what happens to all of that capillary space past where the clot is at? Right. And it can't be used, right? So there's no gas exchange that happens. Remember we talked about VQ mismatch. Remember, ventilation and perfusion mismatch. So VQ, ventilation or V for ventilation, Q for perfusion. A pulmonary embolism is a very common cause of this ventilation perfusion mismatch or a VQ mismatch. Okay? So if you see the term VQ mismatch, that is a ventilation perfusion mismatch. You will see it abbreviated like that pretty regularly. And then pneumothorax. Okay, so those are kind of your top 4 red flags. So when I'm doing my assessment and I have somebody who tells me that they just started having shortness of breath, 10 minutes before they called, and they're speaking in 2 or 3 word sentences, and like it's obvious that they're in some distress, would it be a good idea to start looking at things that could rule these out in succession? Absolutely. All right. So just as important, so your assessment is just as important for ruling things out as it is for finding answers. Okay. And then we have this other term here, paroxysmal nocturnal dyspnea. So that is a very fancy way to say I have sudden onset of shortness of breath while I'm sleeping. That is typically caused by left-sided heart failure. It is typically caused by left-sided heart failure because when you're sleeping, what system is not activated? Which branch of the nervous system is not active while you are sleeping?
I want to say it's your voluntary movements, right?
So typically your voluntary movements wouldn't happen. Which branch of the autonomic nervous system is not active when you're sleeping?
I'm backwards and drawing blanks.
Look at you. So the parasympathetic is typically active, yes. Your sympathetic is typically inactivated during sleep. Or I won't say completely inactivated, but it is much less active. Neither one of them ever really completely shut down. They kind of antagonize each other to maintain balance. But what happens is you're sleeping. You don't necessarily see this when you are awake because your sympathetic nervous system allows you to compensate for this mild left-sided heart failure. But once you fall asleep, what happens to that sympathetic nervous system compensation? It goes away. It decreases pretty significantly. So then with that left-sided heart failure, I get backup of blood where? Where's the blood back up into? Not yet. Left, so. Then we've got our lungs here, and then we've got our pulmonary arteries here, right? And then we also have our pulmonary veins. All right. Now, what chamber of the heart is responsible for pumping blood to the lungs?
The right ventricle.
Okay. So it goes from the right ventricle out to the lungs. And then when it comes back from the lungs, where does it go?
The left atrium.
Okay. From the left atrium, where does it go?
Through the mitral valve to the left ventricle.
All right. Now we'll say that we have a failure here. So we have a left ventricular failure. What happens to the blood in the left atrium?
It's gonna be backed up, can't push.
Eventually, my left ventricle is going to be full to the point where it will no longer flow from the left atrium into the left ventricle, right? Well, now it starts to back up into what?
Pulmonary arteries.
So,
Or veins, sorry.
yeah, so it backs up into the left atrium. Once the left atrium gets filled, then it starts backing up into the pulmonary veins. When the pulmonary veins get filled, then it backs up into the capillaries around the alveoli. And then what do we see? Pulmonary edema, right? So your right ventricular failure is where you see more of the edema.
I just had it backwards.
You just had, yeah, that's why I kind of drew it. So if you visualize the flow of things, it's a lot easier to comprehend the whole thing together. So you can see why the shutdown of the sympathetic nervous system while asleep during the day, we'll say that's a very mild left ventricular failure. So during the day, this sympathetic nervous system allows our body to compensate for that, and we really didn't even notice anything. I don't have any symptoms during the day. But at night, I wake up, a couple hours after I go to sleep every night, I wake up and I'm like gasping for air and coughing. That's because I've got some pulmonary edema from the fluid, from the blood backing up into those pulmonary capillaries. Then we have other mechanical things that can cause a limitation of the movement of air. So something that limits the diaphragmatic movement. Could that be from a trauma? Yeah. Could that be from inflammation? Yeah. Could that be from something that they're wearing? Could be, yeah. Restriction of chest wall movement. Could that again be all of those things we just mentioned? Yeah, absolutely. Then we could have a disruption of the integrity of the thoracic cage. That's a very lengthy way to say we've got a hole in the chest that's not supposed to be there. Okay. Now we move into our primary survey. All right. So our primary survey, what are we looking to do?
Breathing circulation.
Yeah, so the big three, right? We'll say the big four.
Examinating.
Yeah, massive hemorrhage, airway, breathing, circulation. Massive hemorrhage is pretty easy to rule out. It's pretty yes or no question, right? So my guidance to you would be to assess for that on every patient. Get in the habit of assessing for that on every patient, even if it's an obvious medical patient. we used to train like two completely different assessments for medical versus trauma patients, and I don't like doing that because then what happens is you start missing things because you start taking shortcuts. I don't like that. I like to teach you a way to do pretty much all of it,
That's what I need.
and you can apply it to every patient. Kind of like my one formula for all of med math. It's my one formula for all patient assessments. All right. We'll get into that more, not necessarily in this chapter, but we'll get into that more because there's a whole section that covers patient assessment and just like critical thinking and stuff like that. That's when we'll cover that in more detail. But our primary survey, we're looking for immediate life threats. Everybody agree with that's the overall goal of that primary survey, right? We're also going to form our general impression. How many of you guys have heard that paramedics don't diagnose?
Differential.
That is bullshit. If you didn't diagnose something, you wouldn't be treating it. Now, we're not doing, a super elaborate, backed up by significant amount of medical testing, definitive diagnosis. I will give you the fact that we are not giving a definitive diagnosis in the field. Most of the time, you don't get a definitive diagnosis in the ER, right? You get kind of a broad umbrella diagnosis, and they tell you to follow up with a specialist for that body system, right? So you could even go so far as to argue that ER physicians don't necessarily do significant diagnosing. They'd probably be offended by that. So you should probably also be offended when people tell you that you don't diagnose. It's all just semantics. The reason that is a thing is because of how billing terminology is worded. You'll see it called a field impression or a field diagnosis or whatever. It's the same thing. They just call it something different because insurance looks for a way to not pay for things. That's the underlying reason. Okay. So our general impression is our initial, general diagnosis of the patient. All right. Body type. So you will start to recognize patterns with different body types and the common things that you will see with those body types. If I have somebody who's, super skinny, like a 4-pack-a-day smoker, then I'm thinking like, spontaneous pneumothorax, emphysema, things like that. I see somebody who's morbidly obese, I'm thinking more along the lines of congestive heart failure, diabetes, those along those lines. We're going to assess the oxygen demand in the work of breathing. All right. How can we assess oxygen demand? Well, what do we know about oxygen demand?
Like how much the body needs.
Yeah. Everybody has their own baseline for oxygen demand at rest, right?
Yeah.
So do we know exactly what that number is for every patient we're going to come in contact with? No, we do not. Are we going to ever find that number? Not with the tools we have today. Maybe in a few years they'll come up with something. But as of right now, no, we're not. But what do I know about oxygen demand in anybody who has their sympathetic nervous system activated? Goes up from their baseline, right? What about somebody who's like super cold, like hypothermic? What do I know about oxygen demand in those type patients where everything is slowed down? Goes down from the baseline. So I can pretty much tell just by a very brief, less than a minute worth of assessment. I know that your oxygen demand is up or down from your baseline, right? So what are some things our body will do to compensate for an increase in oxygen demand? Hyperventilation, tachycardia, things like that, okay? What about for things that are causing me to have a decrease in oxygen demand from my baseline? hypoventilation, right? So hypoventilation, bradycardia, things like that. I will tell you, hypoventilation and bradycardia are also late signs of increased oxygen demand and a failure to meet that increased oxygen demand. Positioning. Right. What are some things that are red flags for severe respiratory emergencies with just how the patient is positioned themselves? Head bobbing, okay. Tripod position. Right.
I mean, if it's late, they could be just laying flat because they no longer have the energy.
Could be, yeah. That's typically that's kind of what I consider to be in like an impending arrest situation at that point. These people, what do we not want to do with them on the stretcher typically? Yeah. Cool. Now, we have someone who's in an MVC, they've smacked the steering wheel. They're slightly, we'll just say they're unresponsive. What are we going to do to that patient? What's common practice to do to that patient? And how are we going to do that?
We can also hold C-spine while they're in other country position.
Yeah. Now we'll say they smack the steering wheel, no airbag deployment, they're unresponsive, they have a pneumothorax. What happens when I lay them flat? Gets worse. Right. Makes their work of breathing even harder. So then I start to give them positive pressure ventilation. What does that positive pressure ventilation do to the pneumothorax? Makes it worse. What happens to the patient? Yeah. Eventually, yeah.
So like for us, 12 leads can show pneumothorax, right?
No. Not reliably.
I saw somewhere that an invert T wave in the third lead can show potentially a pulmonary embolism.
Potentially, yes. Reliability is not great. It can be another clue in your Blues Clues notepad, right? Like if you're seeing some other signs and you're seeing that, then all those things are building evidence pointing in that direction. But it's not one of those things where if you see that, you should just automatically assume. Does that make sense?
Did Haley send you the picture of ours?
I don't think she sent me a picture, no.
She's supposed to, yeah, the 12 lead, we could see it on ours. And, well, she didn't catch it until after, and then they did whatever the fuck they do and found it. And she looked back at the 12 leads and was like, holy shit, it is there.
All right. Alterations of breathing. We've already talked about most of these things just a little bit ago. Anybody have any questions about these points that are up here now? Increased work of breathing. What if we see somebody who has an increased work of breathing? What should we be expecting?
I mean, they're eventually going to.
We should assume they're going to stop while we're with them. Yeah. So you always plan for the worst. A lot of times it doesn't make it there. Hopefully because we've done some interventions to help stop the progress of whatever's going on with that patient. But I should always plan for them to just stop. So I see somebody who's working really hard to breathe. My fancy little airway kid's going to be sitting on the action area in the stretcher or on the action area in the ambulance with stuff put together and ready to go if they do stop. Right? Don't wait till they stop to start digging through the bags and getting stuff out. Right? Prepare ahead of time. Worst case scenario, you're prepared to do the intubation whenever they just stop. Best case scenario, we'll just roll it back up and zip it back up and put it back in the bag.
I'd rather put it up if we're not needing it. Than
Yep.
have it up.
Yep. You'll only do that once or twice and you'll be like, this is dumb. So another thing with positioning, when we're thinking about like kids and small toddlers, what we want to make sure we're doing with positioning for them.
Protecting their head, protecting their airway.
Yeah. And by protecting their airway, what do you mean?
Like making sure that they're not like slumped over.
Or the opposite, yeah. So what's something we could do for them in that situation? What's something we could do?
Make sure, well, of course, not be an idiot putting them in a car seat or, the Pediamate something. And you can also, we keep like sheets and we keep washcloths
Yeah.
for the just in case factor.
Yeah,
on their head.
well, you typically wouldn't want to put it behind their head. You typically want to put it behind like the base of the neck, top of the shoulders, and that's going to get you the inline. I know what you're trying to say. So primary survey, I'm not going to read all these to you. Review this. These are some like red flag signs and symptoms that you would identify during your primary survey. Okay.
So on some of these,
Yep.
of course, we're going to have shirt up and off
Yeah.
to see tracheal tugging. I've never heard of that one. Do you care to like? So on like a person with normal neck.
Oh,
you will see-
So you'll see it'll be like a sucking in right here. Like this will like every time they every time they breathe, like this little empty space right here will kind of pull, kind of suck in a little bit.
so not often.
I mean, I might have seen it a few times potentially, but it's typically been other way more significant signs and symptoms. And yeah. Altered rate and depth of respiration. Remember our I to E ratio that we talked about? Yeah. Right. So alterations with that. What is it typically? 1 to 2. So typically, we'll just say for simplicity's sake, 1 second of inhalation, 2 seconds of exhalation. It could be in any arrangement that gives you that same ratio. It could be a half a second and 1 second. Yes, it is. So asthma is, 1 to 4 is probably what you should shoot for if you're ventilating an asthma patient. Let's say you've had to intubate an asthma patient. You're worried about air trapping. We're going to shoot for something like 1 to 4. It's kind of a baseline. Now, I have transported patients on ventilators where I've had to set my IDE ratio to something crazy like 1 to 6, 1 to 7, things like that. But for general purposes, kind of a 1 to 4 ratio is a good place to start with those. We say asthma, but any obstructive disease process. So asthma and COPD. Right.
So without capnography, other than knowing the baseline ratio, you wouldn't know the patient, what you need to do for the patient without capnography to see if they're trapping.
That's going to be a tool you can use to see if they're trapping, yes.
But there's more that we'll get into later.
Well, one of it is going to get increasingly more difficult to ventilate them with the BVM because as that fills up from the air trapping, it takes more pressure for you to squeeze your BVM.
And then with that, we could mechanically.
Yes. And you want to detach your BVM, do a little, and it's not like a big push. It's just like a gentle pressure on the chest and then start again. Abnormal breath sounds. We talked about abnormal breath sounds quite a bit the other day. Does anybody have any questions about the abnormal breath sounds component of the assessment?
I suck with breath sounds. I'm good with normal and non-normal. And
Okay.
Fluid constriction.
Okay.
I think it's just going to be listening.
It is.
Making me listen to every fucking patient.
Yep.
Now, which I needed. So I'm not
Yep. So wheezing's pretty easy. Wheezing's pretty easy to pick out. You agree with that? All right. The two that everybody struggles with is differentiating between rails and rhonchi. Rhonchi is going to sound more like, rhonchi is more like a large amount of fluid sound. So like think rhonchi sounds nasty, right? So rhonchi is like blowing bubbles in a glass of milk with a straw. That's kind of the sound you get, like the brr, 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 that kind of sound. Rails is like the Rice Krispies when you pour milk over them. So just like a,
So bronchi will be like the drowning you'll hear in CHF patients.
Yeah.
You need to push that shit out.
yeah, correct. And all right, so I'm going to tell you that these used to be techniques that were used to diagnose or to kind of diagnose how much fluid is in the lungs. But they're really not used all that often anymore. So just be familiar with the terms in this chart.
I've never seen or heard that.
All right. So adventitious breath sounds. So those are sounds that are heard on top of other breath sounds. All right. So those are like extra sounds. So that would be your wheezing, your crackles, your rhonchi, things like that. Because you're still hearing air move with those sounds, but you're hearing those sounds on top of the air movement. That makes sense?
And wheezing would be lower airway constriction versus stridor, which would be upper.
Correct. And remember, what is lower?
Anything
Below the glottic opening.
Oh, below. So, oh shit. Okay.
Stridor is upper, which is typically associated with at or above the glottic opening. And I'm going to throw you a curveball. What if I hear snoring?
That's an obstruction.
And what's causing that obstruction most likely? Tongue. How do I fix that?
Reposition the airway. You can move the tongue with an OPA or NPA.
Are you going to move the tongue with the MPA?
Depends. No.
So the MPA never touches the tongue, typically. Correct.
So, yeah, that wouldn't relieve the snoring sound, though, would it? Or, I mean, I guess it could if more air's going through it.
Yes, it can. I will tell you that MPA is kind of like the lowest level of airway adjunct. OPA is your next step up. It's a much more effective airway adjunct. Problem with the OPA is,
Conscious or gag.
yeah. All right, then we got stridor. So we already talked about that one. Gurgling. What if I hear gurgling?
Oh, then that's secretions.
Or vomit, or blood, or yeah.
So did they mean gurgling there, or
Yeah.
like grunting an actual?
No, gurgling.
Grunting is a thing too.
Yeah. Grunting is like,
Oh, harder work.
In pediatric.
yeah. Grunting is a way for them to increase their PEEP. Yep.
Same thing with the first thing.
Purse lips, yep. Adults usually do purse lips. Peds usually do the grunting.
I'm fucking knowledgeable about this shit.
It's all in the
What, you got
chapter.
kids or something?
I worked a shift with Tucker where he gave me a 5-hour lecture on respiratory system,
Yeah.
which I was very thankful
If you ever work with Tucker again, ask him about the Parker G's 5th day of his 2-day vent class.
Tucker's fun one to work with.
for. It was great.
And then death rattle.
Yeah.
Have you ever heard that? That's kind of like they're barely breathing a little bit, like barely moving any air. It's just kind of like the,
It sounds like there's secretion.
yeah. But there's very minimal air movement.
Constriction would be the death rattle, or
Death would be the death rattle. Means they're moving almost no volume in and out. I'll pull up some of these sounds here in a little bit after we get through the assessment stuff, and we'll just kind of listen to them as like when we're kind of practicing some of the assessment pieces here in a little bit. And then the most ominous breath sound is what? None. We already went through all those. Sputum. So if we have sputum, what would we want to note about the sputum? Yeah. So what if it's like a green or yellow or something like? Yeah. So what if it's kind of red? Bloody. All right. What if it's clear?
Mucus?
Could be, yeah. Yeah.
Pink would be
What if there's a lot of it?
flexion.
Yeah. There you go.
Most of the days of the month.
Yeah. What is the chronic bronchitis? Is what, like 2 or more within 90 days or something like that? Or
Like most of the days of the month, or most of the months of the year.
yeah,
Maybe more years.
yeah. Abnormal respiratory patterns. Yep, we talked about those a decent amount the other day. Anybody having questions about the different patterns? So this is actually a pretty good diagram of, yeah, a good visualization of all those patterns. I actually like this picture. Does a pretty good job. So the Shane Stokes, there at the top, you get deepening and more rapid respirations, and then it slacks off, and then you have a period of apnea, and the pattern repeats. You have central neurogenic hyperventilation. That is just very rapid, very deep ventilation. So you see that in like panic attacks and stuff, but it doesn't last very long. This doesn't stop. That's the big difference there. And your patient's probably not going to be conscious. Apneustic respiration, so that is just a very random, like, no real pattern to that. Your BO respirations there is going to be, think about if you took the apneustic, where those are deep and slow. BOs is kind of that same pattern, but very rapid. So it's just kind of that all smushed together for your BOs respirations. Ataxic means that there's not a real good pattern to define it. Right? So it's not really synced with anything. And then we got agonal gasps. So agonal gasps, you got like the, and then a long period of apnea and another. You should treat that just like you would a complete respiratory arrest. And then we got all these other different breathing patterns here. Many of the ones in this chart are very mild, but this is kind of all of the different kinds of respiratory patterns that you may encounter. I'm not going to read this to you because you're adults and you can read, but do be familiar with these. Okay. Have any questions about any of these offhand? All right. Injury to spinal cord. Why would that be a problem with the respiratory system?
It goes through, it regulates it.
That's right. So two problems. One is a disruption of the signal getting from the brain to the diaphragm. So if the diaphragm's not moving because there's no signal getting to it, what's not happening? Ventilation, right? The other spinal cord injury is a much higher level spinal cord injury. So when I say higher level, I mean higher up in the spinal cord. What you see with those is the diaphragm doesn't necessarily stop working, but we get odd patterns because the respiratory control center signal is disrupted. So the pattern is not regular and normal. Right. Then we have polio. Mm-hmm. Well, so it's not just a hyperbaric chamber. Those things that they used to put them in that called the iron lung, what those did was they actually would form a vacuum which would kind of suck the chest out, and then they would release the vacuum which would allow them to exhale. Serves the same purpose as a ventilator does now. We would not use an iron lung type device now. We would just use a ventilator. That served as a ventilator for those patients. That was a very rudimentary form of a ventilator because we didn't have a method to do the intubation and connect them to a machine that would then ventilate through a tube in their trachea. We were actually causing the whole body movement to replicate the normal breathing process. Cool thing about the iron lung is it's still a negative pressure breathing system.
So aren't people who, like, there's still some people today who are completely dependent on the iron lung? Wasn't that a thing where they could not come off of it for some reason?
I mean, they'd be on a ventilator now.
Okay, so they can, whenever the ventilator was brought up, they can be took on.
Yeah.
Okay.
They couldn't have been then because there was not another option.
That was it.
Yeah. Skin color. What are we looking at with skin color?
Good perfusion.
Yeah. What does that look like?
Normal skin color. And
What's normal?
Depending on them, it's not having cyanosis.
There you go. What about temperature? Is that important?
Yeah, because it's cold, you're going to get a poor reading on SpO2 and poor waveform.
Yeah.
It also could mean shunting.
Yeah. What about if it's hot?
Yeah. Could indicate infection.
There you go.
Release process working.
Yep. Which one is worse, having some cyanosis in like the fingers and the feet, or having generalized cyanosis? Okay. So if you have a dark brown pigment to the skin, that is a sign of methemoglobin being present. Does anybody know where you start to see methemoglobin? So it's more, the venous blood would be, you'd see a more significant change in color in the venous blood. But what kind of like condition would you expect to see this in? This is something you would see in like carbon monoxide type poisoning. Everybody heard of, they're going to be red with carbon monoxide. They will be right about the time you should start doing chest compressions. That is a very, very, very late sign. If they have a red tint, you are way behind. You need to start about 10 minutes before you got on scene and giving them high flow, preferably with high PEEP oxygen. How can we deliver that?
CPAP.
Okay, so if they're conscious, CPAP. If they're not conscious, BVM with PEEP. And then if we intubate them, what do we want to make sure that we keep on that?
Pressure. PEEP.
PEEP, yep.
So for us, how and this might be stupid, I just never done it. How do we add PEEP to a BVM? I know the CPAP has a PEEP setting.
You just plug the PEEP valve into the BVM.
Sorry, so you just pop open a CPAP mask.
No, there's a PEEP valve that goes on to the BVM. The little PEEP valve, click it on there, and then you adjust your PEEP that way. Remember, PEEP only works if you keep the mask on the patient.
Yeah.
If you give a breath and move the mask, the PEEP valve is useless. You might as well have just thrown it in the trash along with the BVM because they're probably not going to do very well if that's how you're ventilating them.
And that'd be the same thing, like if you switch somebody over from the ventilator, you want to clamp it off, that way you keep the pressure in the alveoli open.
So that, depending on why they were on the ventilator.
Okay.
If I intubated you because you've got bilateral open femur fractures and I just wanted to give you enough pain medication that you didn't care, and I needed to intubate you because I gave you enough narcotics to destroy your respiratory drive, then no, I wouldn't really care about that. If I intubated you because you've had COVID for 3 weeks and your lungs look like I've dumped like buckets of sand in there before I did the chest x-ray, then at that point, that's when you'd want to clamp the tube. Does that make sense?
And then we'll get into the medication aspect of it, the right form of not overdosing somebody where you lose all rigid vascular structure. Okay, not vascular.
Yep. Pallor. So this is a fancy way to say pale. Check for dehydration.
Then skin turgor would be reliable unless older populations or people with more elasticity.
Yeah. So things like skin turgor and capillary refill, much better in kids. More reliable in kids than they are in adults. But like very dry, cracked lips, furrowed tongue. Anybody know what they mean when they say furrowed tongue?
Yeah, it kind of looks fuzzy, right?
That, and you can kind of see lines in it.
Oh, like the white cracks and
Yeah. And then sunken eyes. I think that one's pretty self-explanatory. Transport decisions. Now, another place where I'm going to disagree with the authors of your textbook. This says typically transported to the closest hospital. They need to be transported, if they have significant respiratory illness, they need to be transported to a hospital with ICU capabilities. Now, if you can't get a definitive airway, like if you can't do the thing that the patient needs to get them 35 minutes down the road to the place with the ICU, then yes, by all means, take them 10 minutes down the road to the place that can do that thing.
That's why we took that one the other night to park the device.
Yeah. And you know, and it's fine. But if you're able to do what the patient needs to stabilize them enough to drive them directly to a place that has ICU capabilities, that's where they need to go.
And then all of our intercepts carry ventilators, right?
Well, if they're vent certified, like occasionally, so we do not have any full-time intercepts that are not vent certified, but we do have people that are eligible to pick up because they're dual licensed that may not be vent certified.
Like I know like Dom and Noah are. And
Yes.
they run calls and get through, so like
Yes.
CPR, so
Yes.
They could hop in.
Well, and they're not just vent certified, they're both critical care paramedics.
Right.
So they can initiate in the field. As of right now, vent certified paramedics cannot initiate in the field. They're transport only. Patient already has to be on a ventilator and you have to continue that ventilator therapy.
Damn, I didn't know that.
Yep.
But it also would boil down to your narrative and what's needed for the patient.
I mean, basically you're not trained to set it up on a patient that doesn't already have some predefined settings.
Oh yeah, I don't think anybody who's
No, they're not going to because they're going to know that they don't know what needs to be done. Yeah. That is going to change soon. Tennessee's working on fixing that in the way that they have their stuff written in their rules and regulations so that the vent training requirements would change and go up a little bit so that they can initiate in the field, but they'll only be allowed to adjust within like certain parameters. Whereas a critical care paramedic has the freedom to do anything that the device they're carrying can do. Consider taking the patient to his or her preferred facility. So what if it is a patient that has COPD and they have a pulmonologist at Erlanger? Would it benefit that patient to take them to Memorial? I mean, are they going to be stabilized and get the emergency treatment that they need? Yes, but would probably be better logistically for the patient to go to the place where their specialist has the ability to practice, right? All right. We're going to do these few little short slides here on history taking, and then we'll break for lunch. So history taking, we want to investigate the chief complaint, right? So where do we get the chief complaint? From the patient, if we can, all right? So if we can't get a chief complaint from the patient, what do we use in lieu of the chief complaint? Our field diagnosis, our general impression, right? So some common complaints related to respiratory emergencies: coughing, increase or change in color of sputum, fevers, wheezing, shortness of breath, chest pain. The big thing you're going to have to learn to differentiate is chest pain due to something cardiac, something musculoskeletal, or something respiratory.
That'll be all the questions you have to ask the patient.
Yeah, that and diagnostic tools.
Yeah.
So, yes. You know, if they have a known problem, if they tell you they had a fever for 2 weeks, what would that raise your index of suspicion for? Infection. So what kind of respiratory illness is pneumonia would be kind of your, that's your kind of your big red flag there is a significant pneumonia, which could lead to sepsis, things like that. You know, non-delivery of medication. So basically that's just a fancy way to say that the patient's not taking their medication. Travel-related conditions. Anybody know of a travel-related condition that's a significant respiratory emergency?
Are you talking about like COVID-19, or are you talking about them?
I'm asking
flying on a
questions.
plane or sitting for a long time developing
DVT, which could break apart and turn into what?
PE,
A PE. Yep.
deep vein thrombosis.
Yep. Seasonal conditions, non-compliance with the therapy.
Never wearing their CPAP, never taking
Yeah.
their meds.
Sample history. Do we know what sample history is?
Yeah, they messed up the slide. No last menstrual cycle in there.
Would that be part of your... So, the way it's presented is in general for all patients. But if you did have someone who was a female in childbearing age,
Yeah, this one would be really uncomfortable.
yeah. I'm going to tell you, realistically, like 10 to 60.
15-year-old girl, and I'm like, I'm so sorry.
Yeah,
Gotta ask.
yeah. Yeah, if you're working with a female partner, could you let them ask those questions? Absolutely. Do whatever makes your patient most comfortable. Even if you're the medic and your female partner's a EMT, or hell, even if they're an AO, could you guide them in the questions to ask
Yes.
so that maybe the patient feels a little more comfortable having that direct conversation with them versus the direct conversation with you? Potentially, yeah.
Every EMT should be trained on how to put on a 12 lead.
They are if they come through my class.
Yeah. But Puckett's rules were made for the stupidest person in the room.
Well, that's because nobody was driving them away.
Yep.
We're working on that.
Loving it. I had somebody ask the other day, he's like, why? Like the old protocol would hold your hand about like indications, contraindications. I'm like, why do you think it is? I'm like, so the idiots fucking leave.
Mm-hmm. Yep. Any questions about sample history stuff? I'm going to tell you, this is the most important part of your assessment.
Sample and OPQRST is usually going to be side by side.
They are, yeah. They're all part of that history taking.
You probably went to a capable class, but I was taught like OPQRST was only for chest pain.
No.
Like, that's fucking stupid. What
No.
about trauma?
OPQRST applies to anything.
When did this problem start? It
Yep.
Make it better.
Only here.
Oh, no wonder you're so stupid.
So I'm going to...
You make this look like
I'll give you one little quick diagram here, and that'll kind of answer your question with a little bit of a flow chart. So first thing we're going to do,
The NREMT patient assessment flow chart.
well, I mean, no, this is just general practice. Like,
Show up, wear your PPEs, the same safe.
yeah,
Yeah.
but you're not, like, yeah, in scenarios, you kind of have to verbalize some of that. But real world, you're doing that every time you go to a call.
Yeah, we're on scene and putting on gloves.
Yeah.
Number of patients, mechanism of injury, nature of illness. Me? KT dot LAW. Yeah, dot KT at gmail.com. One cool thing, I don't know what type of tablet you got, or that's a computer, ain't it?
It's a Galaxy.
So Emma put me on, what really helps me now, Apple Pencil, I got the slides and I'm able to just beside it. And I can record you and it timestamps it, so I can go back to the slide.
And it'll play where, yeah.
I sent you the respiratory assessment flow chart that notebook.
Nice. I love Notebook, by the way. Cancel your subscription. They're doing a free year for students. I'll email you that.
I couldn't sign up.
You gotta cancel your current subscription, and then after that,
Find the school.
you could give us like a school thing, right?
Yeah, because you had to put in all your school information, like school number and.
So it lets you do other and like input a transcript. Oh, that's horseshit. That shit's $20 a month.
That's why I paid for it, because I saw where they were doing it, but it wouldn't let me sign up. I tried.
Yeah, I'll email Google about that.
Maybe Trump.
Haley gets pissed at me. 'Cause I'm like, what do you want to do? Email the president? I have a buddy who actually works in DC for like one of the some fucking uppy up student, so he's free labor.
I have an uncle that works with the Department of Defense.
Oh, work with DOD. I like the DOD. The Department of War sounds more.
But if you have Verizon, you can add the Google Notebook to your plan for $10 a month.
That's gives you the 2 terabytes and everything.
It does.
Yeah, I made me a notebook and I uploaded the emergency medicines and then these 2 chapters so that I can make sure everything coincides.
I've been using it to give me fake scenarios. That way I get in the habit of just going through a scenario and I don't have to pretend it's real. When Corey gives me one, I can just know how to do it.
I had to dial it back. I told it to like treat me like any lay person doesn't know anything, but then it fucks me up. So I'm like, oh, what medication? Conscription. And they're like, well, conscription starts because.
All right. So, I'm going to start every patient encounter with a scene size up. Everybody agree with that? Next thing you need to do is primary survey. All right. So, that primary survey, we're identifying life threats, issues with our XABCs, forming a general impression of the patient, and getting some baseline vital signs. And by baseline vital signs, that's not where we're doing 12 leads and all that kind of stuff. That's where we're getting a baseline set of our true vital signs like heart rate, respiratory rate, blood pressure, SpO2, maybe a glucose. Okay.
So with the scene size up, would that include like the number of patients?
BSI, scene safety, additional need for additional resources, number of patients, yada yada.
Cool. So we're to.
All that stuff falls in, yeah.
Okay.
Yeah, all that stuff falls in that scene size up thing. And then we get down here to history taking. So history taking, we got our sample. So we got our signs and symptoms, allergies, medications, past history. unless it's mammal that starts at 19 and 28. Okay, like we can guide her 75 or 80 years into the future to get us a little closer to what's pertinent right now. Last oral intake, and then we down here we have events leading up to us being there. All of the stuff for that OPQRST falls under the events category. So onset, provocation, quality, rate, rhythm, severity, and time. So OPQRST should be done on every history taking because OPQRST is how you get all of the answers to the events leading up to us being there. Does that make sense? So OPQRST is how we answer events. So that is how you, realistically, that is how you tie that into every assessment that you do. That is where it falls.
Makes sense. Started having trouble breathing. Instead of just being like, okay, cool, difficulty breathing. Then you go, when did this start?
Yep.
So I've heard respiratory rate two different ways. I know in REMT you're supposed to sit here and count, or I know that's how you're supposed to, but are you just look at somebody, they're breathing slow, they're breathing fast, and then you can also join that with, is this labored, is this a normal rate?
Yeah, so like my primary is I'm walking into the room, that's what I'm doing. As I'm getting actual vital signs, then I want to get an objective number to go with that. That makes sense?
But it's not the priority, of course.
Yeah.
You can do that later.
Does it matter if they're 28 or 32 if they look like hammered shit? No, it doesn't. Does it matter if it's 28 or 2?
Yes.
That matters, but a variation in 4 or 5 in either direction is probably not all that significant. You're just recognizing that it's too high, too low. Right. And then we got our OPQRST stuff there. So onset, when did this start? Anything make it better or worse? What does it feel like? Describe it to me. Rate and rhythm. Other thing that you can include there is radiation. So, yeah. So rate, rhythm, radiation. So a rate would be
Contractions, how often?
correct. Yeah, something like that. So is rate applicable in every single patient? No. Is rhythm applicable in every single patient? No, not necessarily. Is radiation applicable in every single patient? Also, no. But if you kind of get in the habit of looking for all of those on every single patient, then you won't miss it when you get to the patient where it does matter. And then severity is pretty straightforward. And then time, again, pretty straightforward. We talked about, before you guys went to lunch, we talked about their scene size up, primary survey, history taking. So we'll pick back up with our secondary assessment. So the first component of your secondary assessment is your more detailed physical assessment component. So we talked about with that primary survey, are we doing a lot for listening to breath sounds and things like that in that primary survey? Or are we just looking to see if they're breathing or not? Breathing or not, breathing adequately or not would be a better way to summarize that. Kind of what we're looking at there. Do they have an adequate pulse or not? Think of primary survey as a series of yes/no questions, kind of like your start triage type stuff. Whereas as we get into our secondary survey, that's where we're doing all the detailed assessments. So first component of our secondary survey is a neurological exam. What are we looking for in a neurological exam?
Orientation and deficits.
So we've probably already, up here, we've already done our level of consciousness, right? But over here, now, since we're talking about respiratory, what kind of deficits are we really looking for with our neuro exam? Alteration in breathing patterns in general.
So that would include like dysphagia. If they're like broken sentences
How you spell it?
with a P, phagia. Dysphagia. Dysphagia.
No, you got the wrong one.
Fuck.
Dysphagia with a G, just swallowing.
Yeah.
Dysphagia with an S
Oh.
is for speech. So, yeah, it could be, you know,
Phagia.
phasia.
I'll just go to phagia.
Dysphagia. Yeah. So really we're looking for, primarily with neuro, we're looking to see if there's any indication of central nervous system damage that is causing an altered respiratory pattern or something to that effect. And as you'll see, as we go into other body systems in subsequent chapters, there'll be a neuro component for all of those things. At the end of the class, we're going to put all of that stuff together into a generalized template. That's where we'll get our main assessment equation to say. As we finish these, we will add pieces to it, and then you just use what you need for that particular patient. But you start with the same global template, and then as you get through, 1, 2, 3, by the time you get through number 3, you've kind of determined some of these things in number 4 are not going to apply to this person. If it's a 75-year-old male, do I need to assess any, OB system components? I hope not, right? Neck exam. All right. So what would we look for in the neck?
This place trachea.
Yeah. All right. So the one thing I will tell you here, if you see like engorged jugular veins, that's indicative that there's excessive pressure in the right atrium. What would cause excessive pressure in the right atrium?
Blockage.
Right-sided heart failure. So the right ventricle is failing. Where's the blood going to back up to first?
The body.
First. What does it have to go through before it gets?
Inferior and superior vena cava.
If we have a failure in the right ventricle,
Fuck, atrium.
it goes to the right atrium, which does what to the pressure in the right atrium?
Raises it.
Okay. Now, once the right atrium is full, where does that blood back up to? Then to the superior, inferior vena cava, and then so on and so forth until it equalizes at some point, hopefully, right? Tracheal deviation. What does that mean? Where should our trachea be?
Midline.
Should be midline. If it's not midline, what is that an indication of? Yeah. I will tell you that tracheal deviation is a very late sign. You will not see tracheal deviation until that entire side of the chest is already filled with air. As you see over here, see how much air is already in this side of the chest? That is when you'll start to see tracheal deviation. And if you'll notice, it is still not all that obvious. It's kind of twisted here. If you see it where it is grossly pushed off to the side, they need a needle decompression like 20 minutes before you got there. Right? Like, that's one of those emergent interventions you would do during your primary survey if you see that. Okay. Then we'll get through the neck. Next obvious thing to go to is chest and abdomen. What kind of things will we look for in the chest?
Paradoxical chest movement.
Yeah.
Chest.
Now what are we going to listen for?
Lung sounds.
This is where we're going to listen to lung sounds, right? Right. This says feel for vibrations in the patient's chest as they breathe. What might that be a sign of? Anybody know? It's not necessarily a specific disease or anything. Lots of secretions or mucus in the lungs. Right. So, anybody here, you don't have kids, right? You do? Ever had one that's got that super nasty cough and like you like touch them when they're coughing and you can like feel the rattle? That's what they're talking about there. Then obviously any kind of trauma. Right? So from there, we go to the extremities. Any of this stuff look new? Sure doesn't, does it? Now at this point, this is where we would obtain like a full, complete set of vital signs with all the bells and whistles. We've probably been in contact with this patient long enough that specifically if they're legitimately ill or injured, it should be time for us to take another set of our, core vital signs. And at this point, we would add on other things. What are some other things that we might add on at this point with our vital signs? Capnography. All right. So what are our options there for our capnography?
Nasal cannula or
The inline. Yeah. All right. What about some other things that we might do at this point? Any other ideas? 12 lead. Yeah. Those are the two main ones. So if you haven't, depending on the patient, you may put your cardiac monitor on during that primary survey. And especially if it's someone who's super stable, like those are the ones you usually kind of do the primary and the secondary together. Someone who's very unstable, probably going to run through that primary survey from start to finish and then start putting extra equipment on them and things like that, right? So 12 leads, all that kind of stuff. If we didn't get a blood glucose, would now be a good time to get one? Yeah. Stethoscope. Anybody have any questions about how to use a stethoscope? Pulse oximeter. Any questions on the pulse oximeter? What's the problem with the pulse oximeter? A normal pulse oximeter.
values used to hold skin, carbon monoxide poisoning.
Yeah. Can a traditional pulse oximeter probe differentiate between hemoglobin that has oxygen bound to it and hemoglobin that has carbon monoxide bound to it? No. Do they make probes that can? Yes, they do. The ones for the monitors that we have they're the Massimo Rainbow probe. They're called the Rainbow probe because the little emblem on that one it looks like a rainbow. And it's a rainbow logo because it will measure a spectrum of different things. So it will differentiate between carbon monoxide and oxygen levels in the blood. It'll give you both numbers. It'll only give you oxygen until carbon monoxide reaches 10%. And then at 10%, it will switch and it will take your pulse ox number off the screen and replace it with, I think it's a red or like maybe an orange number that will be the carbon monoxide. And it'll have a little CO label next to it instead of SpO2. So, now, at 10%, is that something that's super concerning? No, not really. Let me tell you where you're going to see 10% readings pretty regularly. If you use this probe, I've worked at places where that was like the primary probe that we used for everything. So you put this on like a 2-pack-a-day smoker, it would almost always flip to CO. Now you can manually change it back and forth, but it'll auto change once it gets above 10 if you have that probe plugged in on our specific monitors. All right. Then we've got this fancy oxyhemoglobin dissociation curve. Okay. Now we talked about what the left shift stuff, the right shift stuff was when we were in the physiology chapters. Okay. So go back and review that picture in that chapter that tells you what happens with the left shift and what happens with the right shift. All right. I'll pull up a little diagram of that here in a second. But the big thing to know here is once your SpO2 reading gets to 90, it basically falls off a cliff. So it will very, very rapidly drop from 90 to 70 to 50 to nothing. That is why if you're doing an intubation, you should always have someone who's dedicated to watching the SpO2 number on the monitor. And you should have it set up to where that person is going to tell you when you get to 95, and then they're going to count every single number change from 95 down. And when they get to like 92, you need to quit and reoxygenate your patient and try again. All right. Like if you're like right there and all you need to do is push it forward to be in the trachea, then wrap it up. But if you're still kind of trying to find a view, at that point we need to stop, pull everything out, reoxygenate the patient. Because once we get to 90, the next number you're going to get is going to be like 84. And then it's going to be like 76. And then it's going to be, oh, their heart rate's 40 now. And then you're going to be doing compressions. And that's going to happen over the course of 30 seconds, where it might have taken you 90 seconds to get from 100 down to 90. Okay. I've already mentioned end tidal. And then this mentions our peak expiratory flow. This is just kind of a normal range of values for you to have a general idea of. We're not using devices that measure peak expiratory flow or anything like that. The only device for the pre-hospital world that we utilize that does any of those kind of measurements are a transport ventilator. And then, what do we do after we finished all of this whole secondary assessment process? Yep, so and then for the whole rest of the trip, basically what we're going to do is We're going to run through this secondary assessment piece. When we get down here, after we finish getting our repeat set of vital signs and everything, then we're going to kind of start back over. All right? And you notice that from here we go head to toe, then we do our vitals. Okay? Now, at our head to toe, right? So in our head to toe survey, as we're going through these different body systems, that's when we're going to look for our DCAP BTLS type stuff. Now, when you were taught DCAP BTLS, you were probably taught that in the context of doing a trauma assessment. But can we apply that to a medical patient? Right. Deformities. Cool. What if they've got like the barrel-shaped chest? Could that be a deformity? That's not an acute deformity. That's a chronic deformity. But could that lead my diagnostic decision making? Yeah, absolutely. You know, bruising. Do you have to have trauma to have bruising? No. You know, you have bruising from several other different types of non-traumatic things, you know, blood disorders, chronic diseases, things like that. Repetitive old trauma. You know, you get, you know, little old Meemaw from the nursing home and, you know, she's nice and she's patting your hand and all this stuff. And then you know, she's having some shortness of breath. Nothing appears to be super crazy. She's pretty stable. You're going to go do your 12 lead and you know, raise up her shirt to do your 12 lead and you notice that she's got, you know, 7 different colors of bruise on the left side of her body. And then you figure out, oh, hey, she fell 2 days ago and she's been having worsening shortening of breath since then. Would you have suspected that to be a traumatic injury otherwise? Some of these places you go, you may not get that information. You may not get that at their home because it may be Mama and Papa that live there alone, you know, together, but, you know, no real able-bodied caretaker that's there with them. Neither one of them happened to remember that Mama fell a couple days ago, right? So you see how kind of putting all of this assessment stuff from both of those different types of assessments can be valuable for any patient that you come in contact with. In our reassessment, what are some things that we're looking for?
Intervention changes.
Yeah.
Preventive conditions.
Did my interventions change anything?
Anything on the patient changing or declining?
Yeah. Vital sign trends? Change in LOC, change in work of breathing, you know, any of that kind of stuff. Those are the key things that we're looking for. What if we say we've got this patient who's got some audible wheezing and they were breathing like 30 times a minute and you could hear substantial wheezing even without a stethoscope. And on your reassessment, 10 minutes in, you've given a bronchodilator, started an IV, did a 12 lead, all that kind of stuff, got them on all of your monitoring equipment. Now we notice that we don't hear the wheezing anymore. What's our initial assumption?
They're not moving anymore.
Right? So that's a great way to think, because that's what I was going to tell you that you should be thinking. Most people are going to think, oh, well, my treatment worked. I hear the wheezing, I gave a bronchodilator, now I don't hear wheezing anymore. Most people are going to assume that, oh, well, it worked. But,
Even a normal lung has breath sounds.
yeah,
Absent breath sounds.
correct. And I'm not necessarily even talking about with the stethoscope. We could say that you could hear the wheezing without the stethoscope, and you gave the bronchodilator, and 5-6 minutes into that treatment, you stop hearing any wheezing. Your normal assumption would be that, oh, it's working. But we also need to listen with our stethoscope, because just because we can't hear the wheezing anymore doesn't mean that's necessarily a good sign. It could be because exactly what you said. It could not be moving enough volume of air to even make a noise anymore.
It's common with people with severe asthmatic.
It is.
Especially if they've been intubated or hospitalized before they may not respond to bronchodilators.
Yep, exactly. And this is peak season for that stuff to start showing up.
We're about to have a lot of trouble with our SpO2 readings too, because we're not as really popular in the winter.
Yep. Yep. And realistically, like, the best thing I've found to kind of combat that is pop a hot pack.
That's what I do.
So just pop a hot pack and put a couple folds of the sheet over it or something, and then lay their hand on top of that, and then cover it with the blanket or something. And
Especially the elderly population, you give them a hot pack, they're in love with you.
yes, but that's a great way to counteract some of those false readings that you get, because they're not going to be falsely good readings, they're going to be falsely poor readings. You're going to get sats of 50s and 60s, and you're like, they're talking to me in full sentences without me noticing their breathing. This makes no sense. First rule is don't panic. That's right. All right. So, any questions about this whole general assessment piece of the puzzle here? So, you'll notice today we just kind of filled in things related to respiratory stuff. As we go through this same framework will apply for every other system that we go throughout the year. We will just plug in different specific signs and symptoms that you may catch that are related to that system. Right? And the other way I want to put up here is on this whole head to toe thing. Look, listen, and feel. So if you're looking, you're listening, and you're feeling for all of those components as you go head to toe, I'm not going to say you'll never miss anything, because we got physicians in the ER that have been doing this for 30 years, and they have all of the fancy equipment that the world's best hospital has to offer that still miss things. But if you do this routinely on every single patient, it significantly decreases the likelihood of you missing anything. Now that we've covered how to assess and start to identify problems, now we're going to go into the emergency medical care section. And this is going to talk about things we can do to address some of those problems. Okay. So, main goals for any respiratory emergency. Any respiratory emergency, our main goals are, we want to provide supportive care to the patient. Now that sounds kind of like we're not doing a whole lot. But what that really means is we're supporting their respiratory efforts. We're giving supplemental oxygen. We're giving them some positive pressure if they need it. What are the couple of different ways that we can administer positive pressure? CPAP, BVM, both of those are considered non-invasive. And then, if they need more than that, then we can go to supraglottic, ET tube, things of that nature, right? Standard interventions, okay? So standard interventions. What do they mean by standard interventions? Those are interventions that you should consider on every patient that you come in contact with, right? So oxygen, does every patient need oxygen? Technically, yes.
Oh, well, yeah. No,
They do need oxygen. Not every patient needs supplemental oxygen, all right? So our goal should be to keep their SpO2 above about 94. You will see this number vary back and forth between about 94 and 96, depending on what textbook you're using or what reference material you're looking at. 95 is a good, solid, dead center in the middle number that'll get you everything you need. If you can remember 95, you're good to go.
For testing purposes?
Yeah. So for your textbook-based test, they're probably going to have 94 because that's here. For like National Registry and things that don't come specifically from your textbook, 95 is just a good, easy number to remember.
We took our EMT, Larry Vandergriff, I think.
Mm-hmm.
He was saying that they had changed it to 90. No.
Not that I've seen in any material. So, our goal is to keep it above 94. Our goal is not to get it to 100. When is the one time we want to get their O2 sat to 100?
3 hours finish and intubation.
When we're getting ready to intubate. Otherwise, we don't want to see 100 because we don't know how much above 100 they're getting in their arterial concentration, as we have no way to measure that. We know that if it's below 100, we can safely assume that their arterial concentration is somewhere within 10 millimeters of mercury, either direction of that. So somewhere around 97 to 99 is going to be your target level for absolute best optimization that you can get. But we want to keep it above 94. IV. So does every patient need an IV?
No.
No, they don't. What if I've got back pain that I've had for 3 years and I can't drive myself and I live alone? Do I need an IV? No.
But the hospital will get upset.
Yeah, well, good news is we don't work for the hospital. Now, if we know that when we get to the hospital, they're going to use that to draw lab tests and things like that, is it perfectly okay for us to go ahead and initiate that? If we know that they're going to need it when they get to the hospital. Yeah, absolutely. That is fine. If we know that, well, this patient's probably going to go to the lobby. Is there any point in us starting an IV if we don't need to use it for something? No, there's no reason to inflict extra pain on someone just because you can do it.
It's perfectly okay to tell the hospital that I'm not putting an IV in this patient because I stubbed their toes.
Yeah. Just be professional about it.
For sure.
But yeah, I just be like, I don't have any clinical indication to initiate an IV. There's nothing in my guidelines that I was going to use the IV for, so I had no reason to initiate the IV. Like, that's kind of a generic way you can put that for pretty much any kind of feedback you're going to get. Psychological support. How important is that? Yeah. You know, like, don't be the person that just goes and sits in the captain's seat and never speaks to your patient. Like, there's some patients that's probably the best option for. But most of the time, just carrying on a conversation with these people has just as much positive effect on them as any of the treatments that we do. Right? Position of comfort. Now, is there a standard position of comfort, or is that going to vary from patient to patient? It's going to vary from patient to patient. A good place to start is somewhere like semi-Fowler's, and then you can go up or down. You know, if I've got somebody who has, you know, a lot of curvature of the spine, like they've got some kyphosis and stuff like that, I probably don't want to put them in a semi-Fowler's position because I'm putting a lot of excess pressure on that anatomical abnormality that they have. It's not going to be very comfortable for them. So putting them in a more upright position is probably going to be more comfortable for them. So, you know, how can we determine if our patient is comfortable? Just ask. Be like, hey, lay back here. We can raise you up or we can lay you back. You just let us know. It'll go all the way flat and it'll go pretty much all the way sitting completely upright. You let us know what feels the best for you once you get on here. You know, does that take any significant effort on your part? No, this is being a decent human being. Now getting into the more respiratory specific things. So all of those things are basically things that you copy and paste that for every single patient that you're ever going to come in contact with. That applies to everybody across the board. These are going to be things that are specific to your respiratory related complaint. So we want to decrease the work of breathing. How can we decrease the work of breathing?
Assist their position, their posture, supplemental oxygen, calming them down.
Yeah, all those things, yeah. So supplemental oxygen, so if their oxygen saturation is like 89, do we think that they might work a little less at breathing if we can get their oxygen saturation up to like 95? Yeah, pretty safe bet that they're probably not going to feel like their body's not going to try to work as hard if we can get that up to a more normal level. Are there going to be people that you come in contact with that live at like 92 all the time? Yeah, absolutely. What about things like CPAP and stuff like that? Could that decrease their work of breathing? Yeah, absolutely. Now, if we put it on someone who doesn't need it, what's it going to do to their work of breathing? Probably going to increase it, right? Can everyone tolerate CPAP? No. Coaching can help you a lot, but it will not solve all of those problems. There are some people that just cannot tolerate having that mask on their face because it has to be pretty tight, and it is not comfortable if you have it tight enough for it to get a good seal to work properly. All right, so my soapbox, don't be making the respiratory distress patient walk to the ambulance.
If the respiratory patient refuses to do anything but walk.
Document appropriately. You will find those patients.
We have found those patients.
I can walk. I don't want you. You're not rolling me.
By the time we pulled up to the house, they were already halfway down the driveway. And upon asking them to, just take a second, we'll grab the stretcher, get them loaded up. Absolutely.
Yeah. And I mean, you're going to run into that. You know, that's not the normal, but you are going to find those patients out there. Yeah, just document it. You know, document that, hey, the patient was ambulating towards the ambulance as we pulled in the driveway. We instructed the patient to stop and wait on us to get the stretcher, and they said that they did not want to get on the stretcher. They wanted to walk to the ambulance.
Old crew to go fuck themselves.
Make sure you put your quotes around it. Yeah. Relieve gastric distension. What tool have we learned to use in the last couple weeks that we could use to help relieve gastric distension? Yeah, Inject tube, right? Don't bind the chest or have the patient lie on the unaffected lung.
Put
Yep.
them in the prone position for the whole transport and lose your license.
Nah, we transport people prone all the time when COVID.
Really?
I put together a guideline for prone CPR and everything in the aircraft. We're transporting intubated people prone. Now, it is not good practice to transport people prone. There are reasons that you would want to put a patient in a prone position. Severe ARDS. We haven't really talked about ARDS yet. We will in the second half of this lecture. So like ARDS, you got severe inflammation in the lungs, and by placing them in a prone position, if you think about the lungs, they really kind of set more towards the posterior part of the chest wall. So if we put them in a prone position, there's typically less adipose tissue and less force pushing down on their chest, so it decreases their work of breathing and it increases their gas exchange. Now, that's not something you would want to do with just random person I picked up out of their house. That's typically something you make a decision of doing after your frontline treatments are not improving the patient. Like, you have to make a conscious decision to do that. It shouldn't just be they're having some trouble breathing. Let's make them prone. Because what's the problem with a patient in a prone position in an ambulance?
Bumping, can't access the airway freely.
Right. How easy is it for me to assess their airway and all that kind of stuff if they're prone? It's not easy. It's very easy for me to miss stuff. Okay. And again, don't bind clothing. So we're probably not ever really going to be binding like clothing, but what is something that we do have access to on our stretchers that could cause a problem with ventilation? Putting the straps on way too tight. Guideline for the straps, buckle them, snug them down to where you can easily slide a finger between the strap and the patient. If you can easily slide a finger between there, it is tight enough to do what it's meant to do, but it is not tight enough that it's going to impede their work, it's going to impede their ventilation.
What if they're like super combative?
That's a whole different story. Using them to help restrain a patient to protect yourself or them, that's a little different than what we're talking about here. Now, what do we need to be very mindful of if we do that?
EMS, watch their respiratory rate.
Correct.
Don't wrap it around their throat.
Well, yeah. Providing supplemental oxygen, administering bronchodilators. Anybody having questions about the bronchodilators? All right. So, bronchodilators are ineffective for pneumonia. Why is a bronchodilator ineffective in pneumonia?
Because bronchodilators are used for smooth muscle non-infection.
Right. And typically your problem with pneumonia is not swelling and inflammation. It is buildup of infectious mucus. Right. So the bronchodilators don't directly improve their condition. And I'm going to give you a little caveat here at the end. Pulmonary edema. Do bronchodilators directly improve pulmonary edema? All right. And then heart disease. Bronchodilators directly improve respiratory issues related to heart disease? No, not really. However, bronchodilators may allow me to get better pressure into the alveoli to improve gas exchange. So while they are not directly effective as a standalone treatment for that process, when used in conjunction to provide better positive pressure ventilation, they can be useful in these conditions. Yeah. But I'm using them in conjunction with the tool that is going to fix the problem.
Not just thinking of the first line treatment.
Yeah. Yeah. So, fast-acting bronchodilators, what's our What's our primary fast-acting bronchodilator? Albuterol. All right. How do we administer albuterol?
An nebulizer, put oxygen tubing to it at 6 to 8. Deliver.
Yeah. How do we know when we have the right setting on our flow?
Misting.
Get good mist. Don't have any big droplets flying out the end. If you're still getting some droplets that are intermittently coming out, you need to turn your flow up a little bit more. And that varies from device to device, right? Somewhere between 6 and 10, you're probably going to find your setting that you need, but that will vary from manufacturer to manufacturer. All right, now we have meter dose inhalers. Do we carry meter dose inhalers? Could we assist a patient with their meter dose inhaler? Yeah, absolutely. Could that be quicker than us setting up a nebulizer initially when we're like walking in the house and they have it on the table next to them? Could I assist them in taking a couple of puffs off of their albuterol inhaler while my partner's setting up a nebulizer? Absolutely. Nothing wrong with that at all. So what is this little clear plastic piece here on the end of this? Anybody know what that's called? It's called a spacer. And what that allows is for you to depress the inhaler and it will shoot out the mist into that spacer and then they can breathe in. And what that does is that decreases the amount of the medication that sticks to the mucous membranes in the mouth. A lot of times if you point that like up or down, most of the medication is going to hit the top of the mouth or the tongue and not make it into the lungs. So using a spacer is good practice with any metered dose inhaler. All right, let's see. So dry powder inhalers. Anybody know what kind of medication is typically in a dry powder inhaler? It's typically some sort of steroid, typically some sort of inhaled steroid. And it's a very, very fine powder. So one that is pretty popular is Advair. Comes in like a little round type disc and it's kind of a purplish color. And you like spin the dial to load a dose and then you inhale on it. And it is very fine powder that you're inhaling out of the container into your lungs. And then we got some of these others. We've got leukotriene modifiers. Can help with allergic reactions. These are things like Singulair, stuff along a couple other drugs. I can't think of another name brand that's easy to remember off the top of my head. Singulair is the one that really comes to mind. Then we have electrolytes such as magnesium. So magnesium is a relaxer. Yeah. So what do we have to be mindful of if we're given a smooth muscle relaxer? Hypotension. Why would we need to be mindful of hypotension? Yeah. Corticosteroids.
Effective, but they're effective later.
Yeah. But when do we want to give them?
ASAP.
We want to give them early. I don't want to delay my emergent treatment to give them. I want to start my inhaled bronchodilator treatment first. Then you'll move on to something like magnesium or our corticosteroid. Okay. What patient population should you, there's two specific patient populations you should be very careful in giving corticosteroids to.
Diabetics and renal issues.
So renal issues, that's kind of a blanket one for pretty much any medication.
Yeah.
So people with poor immune system or like people in with signs and symptoms of sepsis or a known infectious agent. So if I have someone that I'm like, oh, they probably got a really nasty pneumonia, I probably don't want to give them a steroid. Now, if I need to give them the steroid to be able to get them to ventilate, can I do that? I can, but it will most likely complicate their long-term process. However, there are cases where it is appropriate to make that decision. You need to think about the long-term effects of what you're doing before you just do it because you can. Right? So you got little old Meemaw with pneumonia and you're like, oh, IV O2, monitor, albuterol and steroid. Because shortness of breath. That's what I do for shortness of breath. And then, 4 days later, you see Meemaw's name on the sign of the funeral home, at the funeral home because she was septic and you just fed the bacteria in her body the best meal they've ever had. Right. So you can do inhaled steroids. We don't have inhaled corticosteroids, but there are things like the Advair and things like that. Those are those inhaled corticosteroids. The thing about the inhaled corticosteroids is they do not have the same depression of the immune system effects as the IV corticosteroids do. Because where do they go? Directly to the lungs. They're not going to the bloodstream. They're going directly to the tissue in the lungs. So most of their effect is concentrated in the lung tissue. So we don't see a huge change in their immune system function when we're doing the inhaled steroids. And I can see your wheels turning. That doesn't mean like nebulize the Decadron.
Oh, no. I don't think nebulized we give it that we have.
Yeah. IV corticosteroids, there's no real significant long-term effects from a single IV bolus dose. Okay? So even on that sick patient that may have an infectious process, you're probably safe to give them a single dose. Okay. No real research that shows that it makes a negative impact on them at a single dose. Problem is that what if we didn't communicate that we gave a dose? And then the ER didn't communicate to the floor that they gave a dose. And now what happens? Now we got a problem, right? So that's where some of that stuff compounds and becomes a real issue.
Usually we'll just throw 10 milligrams of Dex in a flush since the 1 cc's won't fit the
Yeah. The other thing you can do with it is you can squirt it in a 100 bag and spike it with a 10-drop set and run it wide open. It gets you a similar effect. Vasodilators. When would a vasodilator be?
nitroglycerin.
Yeah. When would that be useful?
CHF exacerbation.
Yeah. So more generically, we'd call that just pulmonary edema.
Hypertension, right? Too. If it's severe hypertension.
No. We should not be treating hypertension.
Symptomatic hypertension?
Treat the symptoms. They're hypertensive for a reason. Their body has their blood pressure at 200 because it's trying to perfuse something that's important. And if you stop that,
Compensation mechanism's knocked out in the body.
and typically that important thing that they're trying to perfuse is typically the brain. So that is why we no longer have a guideline for treating hypertension.
Oh, that was been taken out? Because I've heard a lot of medics say if it's over
Yep.
something.
That is, no, that is gone. That is no longer in there. I did not take away the ability to treat hypertension. What I did is you must contact medical control before you treat hypertension directly. Now you can treat hypertension by controlling pain, things like that. Most of the time that fixes the hypertension problem, fixing the underlying cause. So you got to identify the underlying cause. Yes. Don't just treat the number on the monitor, treat the actual patient. find the problem and treat that, and that will typically solve the change in the blood pressure that you've seen.
I may have to use it.
That's fine. We got like 12 more, and we're gonna be completely done with lecture. So restoring fluid balance. Pretty self-explanatory there. We talked about fluid balance a lot in our A&P stuff. Any questions about why it would be important to make sure that it is where it needs to be? Diuretics. What kind of conditions would diuretics be useful for? CHF would be a specific one, but we could just, at this point, since CHF is technically a cardiac emergency, we could say pulmonary edema. Because there are other things besides CHF that will cause pulmonary edema. Okay.
We used to carry Lasix. I saw in the drug cabinet that a box left with furosemide.
Yeah. The problem is that, like, realistically, it's not effective in the field because most people that you would want to give it to are already on it, and you got to give them extreme doses to even see an effect. Support or assist their ventilations. We've talked about this until I don't think there's anything more to talk about. We've talked about the negative pressure system. Any questions about using a bag valve mask device?
No, have you seen the ones that you can set the volume at and it won't inflate past that?
Mm-hmm. Or you can just watch for chest rise.
We can, fire department can't. That's why I like it. Fuck it, give them a PD bag. Fuck that up.
So the one thing I do want to do a little quick refresher on is what is the difference in CPAP and this BiPAP or BPAP, depending on what manufacturer you have.
BiPAP can be one expiratory pressure and one inspiratory pressure.
Correct.
Set it different, and then CPAP is the same for both.
Same for both, yes. That is exactly right. Then we have automated transport ventilators. So these are typically pretty simplistic devices. So you set a volume, you set a rate, and that's typically all you set. So it basically is like an automated BVM.
But critical care medics can adjust the PEEP on them, right?
If you hand me that as a critical care paramedic, I'm probably going to toss it.
What?
In your license.
An automated transport ventilator. These are literally just an automated BVM.
Oh,
Like, these are not things you can change a whole bunch of settings on. Okay. You were thinking of a real ventilator.
yeah.
This is an automated transport ventilator, which in the state of Georgia, transporting an automated transport ventilator is an EMT skill.
So we could technically get those on the truck.
We could, yes.
Just money and not a lot of practical use.
Not a lot of practical use for them. The only time that they realistically are useful in the field is in a CPR.
Yeah.
And
We don't CPR MAI people enough to be like, we need this.
correct. And you typically don't have an issue with being able to adequately ventilate your patient.
Yeah.
You know what I mean?
It's like 30,
Yeah.
35 minutes.
So, intubation. Anybody have any questions about intubation? Now, this only says one. There are two patients that you would want to use intubation as a very last resort in patients with any kind of chronic obstructive pulmonary disease process. There's already a lot of stuff there. They already have a problem with pressure buildup inside the lungs. So switching them to a positive pressure system, I can cause increased inflammation. And they are very difficult to wean back off of the ventilator later down the road. Okay. So asthma and like severe long-term COPD patients, sometimes you have to. I've intubated my fair share of severe asthma patients because nothing is working, and like they're not. The O2 sat of 70 is going to kill them way before my.
Don't worry about extubating somebody.
Yeah, like if I didn't do the intubation, we weren't going to have to worry about ever doing the extubation kind of situation.
We've started asking in our sample if they've ever been intubated from their
Yep.
disease process, and sadly, here recently, we've been getting a lot of people.
Yeah.
Like, yeah, I've been intubated 7 times. I use a Mac 3 and ridiculous shit.
All right, let's see.
There's one guy who will tell you he has a ketamine that the hospital uses on him. I'm like, what the fuck? We're not doing that.
All right. So the last kind of thing here as an emergent use situation, we can inject beta-agonist subcutaneously. Okay. So one of those would be,
Epinephrine 1 to 1.
okay, Epi's more alpha.
No more epi.
No. You can do albuterol.
Oh,
Now this is, I would have to look and see if our formulation that we have is even compatible with the injection route. I don't know if it is or not.
I know it lets us inject epi, but that's for.
I didn't say it was in the protocols. I said that it's something that you could do in general.
Sending it up as a trick question. That's why I was staying far away from it.
But
What would it still be the 2.5 milligrams?
yeah. But typically it's not going to be like the same form. It's not going to be the same concentration as what you get for the premixed nebulizer ones. So typically that would be the kind that comes as 2.5 milligrams and 0.5 milliliters. That would be the concentration you would want to use for subcutaneous injection. You could not, the ones that we carry are in 3 milliliters. They're already pre-diluted. You're not going to inject 3 milliliters subcutaneously. I mean, you can, but I wouldn't recommend it.
I was envisioning myself doing it like they're a turkey.
Yeah.
All
All right.
Order the nebulizer.
So, anybody have any questions about the general emergency treatment? Now, you notice that we didn't go into any super specifics for any super specific disease process yet, right? That is going to be part 2 of this chapter. Part 2 of this chapter is divided up into upper airway problems, lower airway problems, and problems that affect the respiratory system but are not contained within the actual components of the respiratory system. So those are the 3 sections that we will finish up next week when you come back to class.